Good evening, participants and delegates, for joining today's webinar on Shield Connect. And today we are coming with the third episode of Icons in Conversation with Dr. Ritu. So before we start the introduction, let me give a little introduction of our page, and then I will give introduction of our speaker as well as a moderator for this topic. So let me share my screen. So this is our page shieldconnect.in, and you can see there are various sections available on this page. So the first page is regarding the blog section. So you will find all the blogs written by the eminent speakers and doctors. Then we have the second section, that is the webinar section, where you will able to find all the webinars, upcoming webinars, as well as the past webinars that we have done on our page Shield Connect. Then we have awareness pages like PCOS awareness page, menopause awareness page, immune booster and COVID-19 related page. So if you click on any awareness page, you will able to find all the videos and blogs related to those pages. Like for PCOS awareness, you can find various videos are available in different languages. Then we have our leader page, where you will find all the key opinion leaders who are connected with our Shield Connect page. Then we also have a special day pages like Hypertension Day, Mother Day, GDM special. So if you click on any day related page, you will able to find all the blogs and videos related to it. Like if you click on GDM, you will get all the videos related to GDM. So now let me give an introduction for our speaker for the day. And the topic for today is delaying the menopause through ovarian tissue cryopreservation. And the organizer is our Dr. Ritu S. Santwani. So let me start with the introduction. Ma'am has done MBBS, MD, ART from NUHS Singapore, and ma'am is currently director of Pune Test Tube Baby Center and Shamwell Women Clinic from Pune. And for today, our guest speaker who is going to take the topic is Ma'am Ellen M. Manalo. Ma'am has done MD, MSc, FPOGS, FP, SRM, FPSG, and ma'am is a professor of University of Philippines College of Medicine in Philippine General Hospital in Department of Obstetric and Gynecology, as well as Division of Reproductive Endocrinology and Infertility. Ma'am is former chief and of Division of Reproductive Endocrinology and Infertility in University of Philippines. Ma'am has done MSc in Biotechnology of Human Reproduction and Embryology from University of Valencia in Spain. Ma'am is currently Vice President and founding member of Philippine Society for Fertility Preservation from 2019 till 2022. And ma'am was president of Philippine Society for Reproductive Medicine in 2009, as well as president for Philippine Society for Climatic Medicine in 2008. Ma'am was also board member of Philippine Board of Obstetric and Gynecology from 2006 to 2007, as well as in 2018 to 2020. Ma'am is associate editor for Journal of Aspire Journal in Fertility and Reproduction section, and ma'am is also international editor and reviewer for Bangladesh Journal of Fertility and Sterility. And ma'am has also awarded with through Howard and Conchita Redmond Professorial Chair, University of Philippines College of Medicine. So I welcome you, ma'am, on our platform for today's topic and today's webinar with Dr. Ritu. So, ma'am, I hand over the session to you, ma'am.
Yeah, thank you, Nishan. Thank you, Shield Connect. Very, very warm welcome to our very dear friend, Dr. Ellen Manalo. So, friends, very warm welcome to all of you, all the friends who have joined all across the geography. Friends, we are continuously doing this series every Thursday at 8 to 9 p.m. Indian Standard Time. In this, every week we are having a one expert one keynote speaker across the geography and having a conversation with them on the different topics. Post topic, you can ask your queries. And today I'm very much delighted and thrilled to have my very, very dear friend, Dr. Allen. This is my third session with Dr. Allen. I know Allen is having a very, very busy schedule, but I'm very, very much grateful to her. In spite of having a busy schedule, she accepted my invitation. So a very, very warm welcome, dear Allen. So earlier, those who have attended my academic marathon, which was highly appreciated by all, the Allen session was the highest scorer in that of my session. I can proudly say that. So today, Dr. Allen is going to share with us a very, very important topic regarding the ovarian cryopreservation for the delaying of menopause. So a very, very warm welcome to all of you. So now first we will go for the lecture and later on we can have a discussions. Yeah, a very warm welcome, Dr. Allen.
Thank you, Ritu. And indeed, it's really an honor for me to be joining you tonight. So welcome and good evening from the Philippines. And as mentioned, I'm going to be talking about delaying the menopause through ovarian tissue cryopreservation. Okay. All right. Today, it is predicted that a good 50% of all girls will live to over 100 years of age in many parts of the world. And as a consequence of this extended longevity is that a much greater number of these women will be spending a good portion of their lives in this estrogen deficiency state. And together with menopause, we have the problems of cardiovascular disease, osteoporosis, and cognitive decline. And in parallel with this increased life expectancy will be an undoubted increase in the medical and the financial burden for treating menopause-related conditions. And we know that the mainstay in the management of menopause is pharmacologic HRT, especially when you're dealing with a patient who had early menopause, more especially in the patient with premature ovarian insufficiency, where you want to give your pharmacologic HRT at least until the average age of natural menopause. And you know that HRT can effectively compensate for the loss of the ovarian function, ovarian hormone production when it is delivered at an optimal dosage, at an optimal frequency, and at an appropriate time. However, pharmacologic HRT is not integrated into the hypothalamo-pituitary axis, which normally would facilitate a feedback and regulation of the dosaging and timing of these circulating hormone levels. So what you have, in effect, is a consistently higher serum concentration of all these hormones compared to normally produced hormones by the functioning ovaries. So let's review what happens to the ovary from birth to menopause. So that at fetal life, you have about 100 to 2,000 of these primordial germ cells, which enter a massive proliferation process. So that at mid-gestation, this is at 5 to 6 months age of gestation, this female fetus will have several million potential oocytes, 85% of which are lost before birth. So that at birth, only about 1 million of these oocytes will be found in each ovary. And all throughout the reproductive life, you have a continuous decline in the follicle numbers so that most follicles will be undergoing atresia. You have only about 450 of these oocytes actually going to be used or released on a monthly basis. And round about menopause, you only have about 1,000 to 1,500 of these follicles remaining. You have a very low follicular density so that the majority of the follicles now will be resistant to the stimulation by your gonadotropins. And so this is how we see the ovarian reserve throughout a woman's life. And you can see it gradually goes down until the woman reaches the menopause. So with all this wastage going on, with all this follicular atresia going on, wouldn't it be a great idea if we can harness some of this ovarian tissue around about the time when you expect a fantastic follicular density, which is around about 20 to 25 years old, and store this and probably re-implant it at the time when the woman reaches the menopause so that you can actually extend the period of the menopause. And so here we talk about the main topic, which is ovarian tissue cryopreservation and transplantation. And as we know, it's been around for the past 2 decades. It's gaining ground as a successful method for fertility preservation in women facing a potentially sterilizing gonadotoxic treatment. And currently it is estimated that more than 10,000 girls and women worldwide have undergone ovarian tissue cryopreservation, resulting in more than 200 live births following retransplantation with a live birth rate of 25 to 30%. And if ovarian tissue reimplantation is capable of restoring ovarian activity after the menopause induced by chemotherapy, radiotherapy, surgery, or a combination of all these treatments, could we not use it to recover sex steroid secretion after natural menopause and prevent menopause-related conditions in the aging population? Could ovarian tissue frozen at the young age followed by reimplantation upon reaching menopause be the anti-aging therapy of the future? Okay, so we review the technology of OTC and ovarian tissue transplantation. So when we talk about ovarian tissue cryopreservation, we know it's a fertility preservation method in which the ovarian tissue is surgically retrieved and cryopreserved afterwards. And after being thawed, so this would be the time when the patient now reaches menopause, the ovarian tissue is grafted back to the patient either in an orthotopic site, which is inside the pelvic cavity, or in a heterotopic site, which is outside the pelvic cavity in the subcutaneous regions, maybe in the forearm or the abdominal wall. And we know that this is technically feasible. It's been done for 20 years. But as far as menopause management is concerned, it's still not proven. And in contrast to other fertility preservation methods like egg freezing or embryo freezing, with ovarian tissue cryopreservation, the transplantation of ovarian tissue not only restores fertility, it also restores ovarian endocrine function, so that after orthotopic reimplantation, you find that a good more than 95% of these patients would have restoration of their ovarian endocrine function. And duration of ovarian activity on the average would be about 4 to 5 years, but can even last up to 7 years, depending on the follicular density that you put in. So the main indication would be for your cancer patients. So these are patients who are undergoing gonadotoxic treatment. So you want to safeguard their fertility because they are at risk of ovarian insufficiency and infertility. It is the most promising way, OTC is the most promising way of preserving a patient's fertility when you're dealing with gonadotoxic treatments, which cannot be delayed, okay? Also in prepubertal girls, where the protocols for ovarian stimulation and oocyte collection are not possible. Likewise, you can use OTC for non-malignant pathologies where there is a risk of premature ovarian insufficiency. So in patients undergoing oophorectomy for benign ovarian conditions like patients with ovarian tumors, those with ovarian torsion, those with endometriomas. Likewise, in thalassemias and aplastic anemias where you will be using bone marrow or stem cell transplantation. Also in patients with endocrine or genetic diseases which predispose to POI, like Turner syndrome or galactosemia, and also autoimmune diseases which will require chemotherapy, like your severe lupus carditis, glomerulonephritis, or your Behçet's disease. And more recently in literature, you will find that ovarian tissue cryopreservation is now a strategy to postpone the menopause in healthy women and also to postpone pregnancy in healthy women. So very much like social egg freezing. So instead of freezing the egg, you're going to be freezing ovarian tissue. So what is the evidence? You will understand that the literature in this topic is very scarce. So we do a historical review so that in 2001, Vallejo reported on 3 patients who underwent total hysterectomy and bilateral salpingo oophorectomy, and this was immediately followed by reimplantation of their ovarian cortical tissue back into the abdominal wall. The ovarian secretion only lasted for a short period, in these cases, 4 to 5 months, and it was surmised that these women were actually perimenopausal. The ages were 45 to 49 years old, and they already had depletion of their ovarian reserves, which is why the lifespan of the ovarian secretion was very, very short. In 2005, we have Kiran reporting on a 44-year-old who was operated on for fibroids. This patient also had her ovarian tissue in the form of 10 cortical strips implanted back into the rectus abdominis, just above the phalangeal incision. And 18 months later, you see evidence of ovarian function. There was folliculogenesis and there was normalization of ovarian hormones. And Kim reported in 2012 and 2014 about 4 patients ages 27 to 37 years old undergoing ovarian tissue cryopreservation between 1999 and 2004, and subsequently underwent reimplantation in 2001-2011. The ovarian tissue slices were grafted to the heterotopic site between the rectus muscle and the rectus sheath. The initial transplantation showed recovery of ovarian function, which was short, lasting only for 3 to 6 months, which is why they did a second transplantation. And this time, this brought about normalization of the FSH and estradiol levels. And this ovarian function lasted for 7 years. And according to Kim, there was even evidence of progesterone secretion from these heterotopic grafts. Likewise, Anderson and Christensen, this is Klaus Heding Anderson, one of the pioneers in ovarian tissue cryopreservation, reported on 4 patients who underwent their first tissue transplantation more than 10 years from the time that they had their ovarian tissue cryopreserved. So these were cancer patients, and 2 of these 4 patients had ovarian activity, which lasted for a long time, 6 to 7 years. And lastly, we have Jacques Denet and Marie Dolman, again, pioneers in OTC, who reported on 100% restoration of ovarian activity with recovery of menses in 11 of their cases. And here they reported ovarian function, which was restored for 6 to 7 years. But these patients were actually less than 22 years when they had grafting, when they had recovery or storage of the ovarian tissue. So at less than 22, you expect that the follicle density is very high. And so that would explain the long duration of ovarian function. So we ask ourselves, is there harm? In other words, if you do a biopsy of the ovaries or take out the ovary, will it bring about infertility? Will it bring about further harm to the patient? And last tells us that removal of 5 to 6 biopsies of 1 centimeter in length and 5 millimeters in width will have little, if any, effect on the fertility or age of the menopause. And you know that patients who undergo oophorectomy for a benign disease remain as fertile as those with 2 remaining ovaries. And according to Jacques Denet and Marie Dolman, you have removal of less than a third of the 1 ovary having minimal effect on the ovarian reserve and subsequent follicular recruitment. Next question. Remember that we're going to be dealing with patients with usually with the uterus intact, and so you have to protect the endometrium. So is there progesterone being produced by ovarian tissue which is grafted to a heterotopic site? And Kim has the most extensive experience in this heterotopic grafting, telling us that yes, progesterone secretion is similar to that observed after orthotopic grafting, and you have about 5 milligrams per ml of progesterone, which given for 10 days is enough to bring about differentiation of the endometrium to the secretory phase. So yes, progesterone is being produced. Likewise, now Suzuki from Japan, who's been doing vitrification of this ovarian tissue, found that heterotopic autografts can give rise to long-term ovarian function with progesterone values more than 10 milligrams per ml during the luteal phase. And lastly, Lee also reported or documented progesterone secretion in his animal model study. So what about cancer risk? You know, we worry about delaying the menopause and the risk of breast cancer and ovarian cancer. So the lifetime risk of ovarian cancer is about 1 to 2%. And with pharmacologic HRT, based on a meta-analysis, the risk is about 0.7 per 1,000 women in 5 years. But you look at the risk factors for ovarian cancer, very important is age, because 50% of ovarian cancers are seen in women more than 65 years. It's also seen in patients who are overweight or obese, who have a family history of ovarian cancer, or who have a genetic mutation, the BRCA1 and BRCA2 carriers, and those with Lynch syndrome. So according to Denet and Dolman, if the biopsy was taken at age 20 to 25 years, the risk of developing ovarian cancer after a 10-year period is actually very low, because the risk, as mentioned, generally increases after natural menopause when ovary is more than 50 years old. We talk about breast cancer risk, and you know that the relationship between breast cancer and hormone therapy is very tenuous, very controversial. Now, we have Rogerio Lobo, who did a reanalysis of the WHI data in 2017, saying that the risk-benefit balance of HRT used in healthy young women aged 50 years or within 10 years of the menopause shows lower rates of all-cause mortality with no increase in breast cancer. However, we have in Lancet in 2019, a publication by the collaborative group on hormonal factors in breast cancer, stating that every MHT type except vaginal estrogens was associated with excess breast cancer risks, which increased steadily with duration of use and were greater for estrogen progestogen than estrogen-only preparations. This is in contrast, however, with an update of the WHI randomized trials, which was published in JAMA by the principal author of WHI, Schlebowski, saying that based on the RCTs, if you're using conjugated equine estrogen alone compared to placebo among women who had a previous hysterectomy, the use of CE alone was associated with a lower breast cancer incidence and lower breast cancer mortality, whereas the use of CE plus MPA compared with placebo was associated with a higher breast cancer incidence, but there was no significant increase in breast cancer mortality. Okay, so we go to the technique. How do you go about it? First of all, you surgically remove the ovarian tissue through laparoscopy. So you can either do a biopsy or you take out the whole ovary. But what you want is a sufficiently large pool of ovarian tissue to allow for greater longevity of ovarian function. So now that the trend is really to take out the entire ovary. And after that, you freeze the cortical tissue prepared to a thickness of approximately 1 millimeter. And this cortical tissue is soaked in cryoprotectants to avoid ice crystal formation and to avoid damage of cell integrity, and stored in liquid nitrogen for as long as necessary, and literature it says it's up to 17 years, and this is at minus 150 degrees Celsius. And when menopause sets in, then you thaw and you transplant it, and we will talk about how you go about transplantation. And usually you expect that full ovarian activity will be resumed in about 3 to 6 months. And take note, this is a beautiful sagittal view of the ovary, which tells you that your primordial follicles are really concentrated just underneath the cortex, which is why only the ovarian cortex is cryopreserved. Okay, so this is how you go about it. This is retrieval of the ovary, and then you take out the medulla. Okay, so you cut the bivalve, the ovary, and take away the medulla, leaving out the 1 millimeter thick cortical tissue. You cut the cortical tissue into 5 millimeter strips, 5 by 5 by 1 millimeter. And then you freeze in liquid nitrogen. You keep it there until the time that menopause sets in, and you put it back into the individual. Okay. So how do you go about freezing? Do you use slow freezing or vitrification? So far, there's no uniform protocol for cryopreservation. In fact, only relatively few centers have really embarked on establishing the technique on a clinical scale. But nevertheless, they make use of cryoprotectants, which will ensure that you penetrate the entire cell membrane. So the cryoprotectants used will be ethylene glycol or DMSO, together with a non-penetrable sugar molecule like sucrose, which will further facilitate reduction in intracellular water activity. And so which combination of cryoprotectants would give you the most efficient survival of the primordial follicles is still not known. But generally, when we're dealing with ovarian tissue cryopreservation and the resulting pregnancies, most of the pregnancies, we talk about more than 200 pregnancies in those patients who've undergone OTC, then majority underwent slow freezing. Only 3 pregnancies were due to vitrification. This is from the group of Kawamura and now Suzuki. So we talk about ovarian tissue transplantation. This is actually the more devastating aspect to follicle survival than the freezing procedure. 2/3 of all follicles are lost during this transplantation, and this is largely due to ischemic damage to the tissue pending transplant and revascularization. And techniques to improve transplantation have been resorted to bring about better perfusion, bring about more oxygen and nutrition to these ovarian tissue, the ovarian tissue. So a transplantation can be done orthotopically, which means it goes back into the pelvic cavity, either in the remaining ovary or close to it, or heterotopically, meaning to say it's outside the peritoneal cavity. So it can be in the forearm or in the subperitoneal pocket, in the anterior abdominal wall, or in the lateral pelvic wall. Okay, but because we're dealing with women who just really want to delay their menopause, who are not really concerned about fertility restoration, then the graft site can be done heterotopically. This is outside the pelvic cavity, either in the forearm or the rectus muscle. And the advantages of the heterotopic transplantation for ovarian function restoration would colonoscopy one. It's obviously less invasive because you don't have to do laparoscopy. You can repeat the transplantation again and again. Okay, and it's feasible even when you're dealing with severe pelvic adhesions. And of course, it's a preferred method for restoration of ovarian function, but not for fertility. But we will be talking about fertility also later on. Okay, and so this is just a picture of the abdominal wall where you see two ovarian follicles, quite obvious. So this talks about the duration of ovarian function. And according to Klaus Eding Anderson, it can be as long as 10 years, but according to Jensen, it can be as short as 1 to 2 years. So that the functional longevity of the tissue is highly variable, and it will depend on the age of the patient at the time of the OTC, the size of the ovarian reserve at freezing, and the amount of tissue being transplanted, which is why the tendency now is to use the entire ovary rather than just bits of ovarian tissue biopsied. So in theory, we're actually talking about this cell-based or tissue-based HRT. Using OTC at a young age can be used as a physiological solution to prevent osteoporosis and fractures and menopause-related conditions in the large population of aging women. Now, currently, the majority of women would probably not subject themselves to an elective surgery purely for delayed menopause, but it may be justified. Like say you're dealing with a patient who's already undergoing pelvic surgery for other reasons. She's undergoing cesarean section or appendectomy. So this is something that can be offered as an elective procedure with proper counseling. Nevertheless, we ask ourselves, would women prefer to have regular menstrual cycles up to 60 years of age when readily available pharmacologic HRT compounds can deliver hormones without the bleeding? Okay. Right. And according to Gellert, the group of women for whom the use of cell-based or tissue-based HRT are most likely to become a clinical option would be the thousands of women worldwide who have had ovarian tissue cryopreservation for fertility preservation due to their different malignancies and their genetic conditions. Okay. So here we have UK media, which actually was released in August 2019. And the UK media reported that there's a Birmingham-based company called ProFam, which is protecting fertility and menopause. And they were offering this new procedure that we've been talking about, this cryopreservation of autologous ovarian tissue to delay the menopause through later reimplantation. The company was co-founded by 4 reproductive medicine, world-renowned experts in reproductive medicine. This Ari Kumarasamy, Christiani Amorim, Yusri Afifi, and Simon Fischel. And they're proposing to perform laparoscopy in premenopausal women within 40 years of age to collect sections of ovarian tissue. The ovarian tissue is supposed to be frozen at minus 150 degrees Celsius, preserved in an authorized bank until women reach the menopause, when it is then thawed and transplanted back into the body, where it will replace the function of the original ovaries. Exciting. But shortly thereafter, the British Menopause Society came up with their response. And they said that further evaluation is needed to assess the safety of this technique, its effectiveness, the length of time such reimplanted tissue continues to function. And this evaluation should include a benefit-to-risk analysis, particularly when applied in otherwise healthy women. And the recommendation they gave is that this procedure should be initially assessed in a controlled clinical research trial in order to evaluate its safety, its feasibility before it could even be considered as a potential option in clinical practice. And the International Menopause Society also came up with their response. They were in agreement with and supported the British Menopause Society consensus, and accordingly, you would need more than 20 slices of ovarian tissue to collect this and to cryopreserve this in order to ensure hormonal preservation for that many years of 20 years. And all patients considering this procedure should be thoroughly counseled on the considerable physical, emotional, financial, and time investment involved. Okay, so obviously we all need to look into carefully designed, rigorously conducted studies before this becomes standard practice. Nevertheless, it's important to look into the potential benefits and risks of OTC, especially in women who have already restored their ovarian tissue, women who are on the road to recovery, are in remission from their cancer and wish to use their tissue. Now, several questions are still unanswered. One would be, what would be the minimum hormone level needed for the ovary to maintain normal physiologic function in the uterus, bone, cardiovascular system, and the brain? And what would be predictors of the duration of endocrine function in re-implanted, warmed, cryopreserved ovarian tissues? So here is an algorithm, just a drawing of how we go about it. So you do your laparoscopy. This is from DONNEZ and DOLMANS. So you take out your ovarian tissue, cryopreserve, and at the time of menopause, and you're going to put it back into a heterotopic site here in the abdominal wall. At the same time that you're collecting ovarian tissue, you might want also to collect isolated primordial follicles and incorporate these primordial follicles in a biocompatible or handleable scaffold. So, and you create in the process an artificial ovary, which can be reimplanted. So that would be for fertility reasons. So here, now you're going to combine restoration of ovarian hormone secretion for menopause, for delaying the menopause, and preserving fertility. So that what they advocate is that at 20 to 25 years, you can do your ovarian tissue cryopreservation, and you also can vitrify your M2 oocytes. And later, when pregnancy is desired, you can try natural conception. And once the patient is done with their pregnancy at menopause, then you can use the ovarian tissue that you stored for transplantation in order to delay the menopause. Now, if pregnancy doesn't ensue naturally, then that's the time you use your vitrified oocytes, proceed with IVF. And if it doesn't work, then at least you still have your ovarian tissue that you can use to delay the menopause. Okay. So in conclusion, we have just talked about ovarian tissue cryopreservation and ovarian tissue transplantation to delay the menopause. They appear to be technically possible, and they represent an optimistic view on the potential future use of ovarian tissue cryopreservation. But the burden of repeated surgical interventions must be weighed against the simple, cheap, and readily available pharmacologic HRT medications, which already exist and are administered to millions of women worldwide. And with that, I'd like to thank you, and I will be open to any questions that you have in mind. Thank you very much.
Thank you, Dr. Allen, for a very nice, crisp presentation. As always, your presentations are very crisp and up to the point. We have got a lot of appraisals. Dr. Allen, I have one question. What's your experience with this PRP therapy? Have you tried in some patients this PRP for the menopause?
No. I've done some reading up on it. Okay. In fact, it seems very promising, and I do want to start a study on that one, because they've used it in patients who are menopausal. They've used it in patients with premature ovarian insufficiency, those with diminished ovarian reserve, those who've had so many surgeries, and you know, they've even come up with pregnancy. So it seems to be easy. It's an easy procedure and cheap. And I think you probably have more experience with PRP. Yeah, but I'm definitely going to try it out soon enough.
Yeah, I have tried in so many of my patients, especially in the patients with this menopausal symptoms also, this PRP. Very, very good results. But the problem is this, that is still not FDA approved for that. So what we are doing offline only, because all the patients, PRP is very easy to do and very, very good results. And as you discussed now, this orthotopic and heterotopic for this ovarian tissue. So in your practice, you prefer what? Because in India, some doctors are doing very, very good work, especially in the Gujarat side, regarding this heterotopic. So in your practice, you prefer which one?
It depends on whether you want to do it for fertility reasons. So for fertility reasons, you really have to do it orthotopically. So you want to put it back into the pelvis. Yeah. But of course, there is actually a report of there is a report of a twin pregnancy with heterotopic. So you can still have that, but it's more difficult. Obviously, you have to resort to doing IVF. But if you're talking about OTC and transplantation just for delaying the menopause, then the way to go is heterotopic. It's easy. Anybody can just do it. And you don't need to do your laparoscopy. It can be done repeatedly. So again, depends on what your goal is.
Right. Thank you so much. Friends, if there are any questions, we are ready to take. Although we have received some questions, yeah. And thank you to all of the friends who have joined all across the geography. I'm able to see some of my friends have joined from Saudi, Dr. Nausheen from Pakistan, Dr. Fatana from Afghanistan. So many friends have joined. Now let me take the questions. Yeah. There are so many appraisals are coming, Dr. Allen. Crystal clear presentation, very informative session. Yeah. Yeah. There is one question by Dr. Nishant. Is it safe to perform controlled ovarian stimulation for oocyte embryo cryopreservation in the patients who are candidates to neoadjuvant systemic therapy?
To neoadjuvant systemic therapy. In other words, are we talking about patients who are undergoing chemotherapy for cancer? Yeah, for so long as you have enough, you need 2 weeks, right? So remember that OTC is done when you really have to do your fertility preservation. So you don't have time, you don't have the 2 weeks for ovarian stimulation. But if you do have 2 weeks, if you can delay, if you talk to the oncologist and he's giving you 2 weeks to do that, then you can safely do that. For so long, again, you do that when the patient has a good chance of survival, has a good chance that the chemotherapy is going to bring about fertility loss. Likewise, yeah, there should be a good 5-year survival.
Thank you. Thank you. There's one more question because program has gone live on YouTube also. So we have received some questions there also. Again, the question is from Dr. Nishant only. Can duration of oocyte vitrification impact live birth rates?
The duration, no. As I mentioned in literature, the longest has been 17 years that they actually store the oocytes. But of course, if you're doing it for fertility reasons, you're not going to wait that long, right? So as far as egg freezing is concerned, then pregnancy rate is a good 25 to 30%. When you talk about ovarian tissue cryopreservation, it's also 25 to 30%. So I don't think it makes a difference. And the beauty about ovarian tissue cryopreservation, you're not only storing, you have a potential for storing the primordial follicles, you also have the potential to store ovarian function.
Very true. Thank you. There is one more question. Any chances of fetal growth restriction or miscarriages by, let me read.
Okay.
There is one more question. Yeah. Any chances of fetal growth restriction or miscarriage by ovarian tissue cryopreservation method in future?
Well, they've only had about 200 deliveries. And so far, they say that there's no increase in miscarriage rate. But you have to have your cautions. In other words, if you're going to do your after fertility preservation, you would want to wait about 6 to 12 months before you embark on fertility management, because you don't want to expose a potential, you don't want to increase the risk of teratogenicity. And also you want to get rid of all the effects of the chemotherapy. So it's about 6 to 12 months, but growth restriction, no, generally no.
Yeah. Thank you. Thank you so much. Now, Dr. Ellen, some non-academic questions, because our today's discussion is the icons in conversation with Dr. Ritu. So tell me, is it your dream to become a gynecologist from your childhood?
No, actually, I just wanted to be a doctor.
Okay.
Yeah, I didn't know that I wanted to be a gynecologist until I was already doing my internship. At the time, I wanted to be a neurosurgeon because I felt like, I think that's the top. The brainiest doctors are usually neurosurgeons. But then I thought, if I did that, I'll probably just be growing varicose veins. And I did enjoy my rotation in OBGYN. So I thought, yeah. And I went into RE-I because I didn't know much about it. But I think RE-I is the most exciting field there is.
Thank you. As you are the founder president for the Philippine Society of Obs and Gynec, so you are actually a role model for so many of us. So give us some take-home message or some message if you want to give to the young budding gynecologists.
Well, I'm not the founder of OBGYN in the country because the Philippine OBGYN Society has been around for 75 years.
Okay.
But I'm the founding vice president of the Philippine Society for Fertility Preservation. But I think as a doctor, you cannot stop studying. You know, I mean, there is really just so much to learn. And the more you learn, the more you ask yourself that there's really so much knowledge that you want to attain. And at the same time, be passionate about your work, but also don't forget about your family. Don't forget about the things that count in your life. Like, you know, don't forget about your hobbies. Like I sing, I like designing jewelry, I like dressing up, you know, things like that. So I do find time for those things. And especially now with the pandemic, you know, you really have more time with the family. I would love to travel. This is something that we lost during this pandemic. And I would want our lives to go back to normal, but I don't think we'll ever go back to the way life was. But I think it's important that you love what you're doing. Because as they say, if you love what you're doing, then it's just play for you. It's not going to be work for you.
Very true. Very true. Yeah, totally agreed with you. Yes, all of us who are very very frequent travelers, the traveling is totally stopped. But one good thing from this pandemic that we have got a lot of friends across the geography and lot of knowledge sharing platforms. Here only we can see there are so many friends have joined all across the globe. Dr. Fatana has joined all the way from the Afghanistan. Dr. Nausheen is from the Pakistan, and so many doctors have joined from the Saudi also. So if there are any more questions, Dr. Nishant, are you able to see any more questions?
Yes, ma'am. One more question I have added.
Yeah. Please take it then. I'm not able.
Yes, it is there. Can ovarian suppression with GnRHA during chemotherapy be used in place of cryopreservation strategies?
Okay, we're now talking about fertility preservation outside of delaying the menopause. Well, at this point, the ASCO and the ESHRE say that the use of GnRH co-treatment is still controversial. Okay, so it should be used in patients where, as a secondary form of fertility preservation, you still want to use your egg freezing or your embryo freezing or ovarian tissue cryopreservation, and you only use your co-treatment with GnRH if these are not going to work. But yes, they have been known to improve or protect patients with breast cancer and lymphoma cases. And they're so easy to use. That's why even if GnRH use is controversial, people still use it.
Thank you. Thank you so much. I think with this, we have finished all our questions. So thank you, dear Dr. Ellen, for your time. I know you are very busy. In spite of that, you accepted my invitation. So we are really
anytime.
We are really honored to have you with us.
Ritu, it has been an honor for me to be with you. And I treasure this moment, and really I enjoyed this time, even if it's 11:30. Yeah. But anytime, and maybe I can also invite you to one of our sessions in the Philippines. Thank you very much, everybody. Thank you.
Thank you so much.
Thank you, ma'am.
Before you wind up, I want to thank each and everyone. I am able to see so many of my friends have joined from the Egypt also. Dr. Pro has joined. Dr. Vandana has joined from the Katra. So many friends. Dr. Beena has joined. So many friends have joined all across the globe. So thank you, all of you, dear friends, those who have taken out time. So friends, and Dr. Rashmi also, my dear friend, has joined from all the way from Ranchi. Dr. Sharda has joined. So many friends are there. So friends, please block your time every Thursday, 8 to 9 p.m. Next Thursday, we are having the very interesting conversation with another my dear friend, Dr. Shadi Salim, President of Arab Society. We are going to discuss with him a very, very important topic, ultrasound in infertility. So stay tuned. Again, see you all on next Thursday, 8 p.m. Indian Standard Time. Yeah, over
Thank
to you.
you.
Nishan. Yeah, thank you. Thank you, dear. And thank you, Nishan. And thank you, Chitra, for the excellent platform support. Yeah.
Thank you, ma'am. Thank you, Dr. Manalo.
Thank you, ma'am.
Yeah, welcome.